Hello everyone, welcome to the class on cardiology. So today, cardiology is basically divided into two parts, part one and part two. Today will be part one. So what we'll be seeing today is we'll be talking about ACS, that is acute coronary syndrome, what it has, different types of ACS, the treatment, everything we'll be covering today, followed by inflammation of different parts of the heart. That includes basically pericarditis, myocarditis, and endocarditis. Once inflammation is finished, then we'll be looking around for various causes for syncope, which mainly includes cardiomyopathies. Those things we'll be dealing with. Followed by, we'll be talking about heart failure. Followed by, we'll be talking about hypertension. These are the broad topics what we'll be covering today. Should be possible to cover in next couple of hours. In part two, we'll be mainly seeing or we're mainly going through the congenital heart diseases. That shouldn't take long time, but majority of the time will be spent on discussing about the previous year's questions. Those are basically recall questions. First, let's get into acute coronary syndrome. This acute coronary syndrome includes three things. One is unstable angina, non-ST segment elevation MI. Another one is ST segment elevation MI. This all three comes under one group, which is known as acute coronary syndrome. How does a patient with an heart attack, in a layman's term, heart attack, presents to the emergency department, or with an acute coronary syndrome presents to an emergency department? Basically, he will be having a chest pain. This chest pain, he might describe it as heaviness. He feels like someone is sitting on his chest. He feels heaviness, and this heaviness might be traveling into his left arm, or pain traveling into his left arm or into the neck. So basically neck, it might relate to neck, or it might relate to the arm. Sometimes it might relate to the right arm also. This one might be associated with profuse sweating. He will be sweating a lot. What do I mean by profuse sweating? He'll be drenched in his sweat. It will be like he's been dipped in a bucket of water. So he'll be profusely sweating. And this one can be associated with shortness of breath, difficulty in breathing. Especially we see it in anterior wall MI. If they're complicated with pulmonary edema, that's when they'll be having difficulty in breathing. We call it he's in heart failure. Sometimes there might be GI symptoms also, like nausea and vomiting. All these symptoms can be present in unstable angina, NSTEMI, or STEMI. It doesn't mean everything will be present. One or the other thing can be present. For example, chest pain can be absent in a patient who is diabetic. This is mainly his nerves might be affected because of diabetic, and he might not perceive the pain at all what a normal individual like you and me who are non-diabetics perceive the pain. That's why he may not come with the pain. He might just come with an profuse sweating, or he might just come with a shortness of breath. That again should trigger, or one of the differential diagnoses should be acute coronary syndrome. What is the difference between unstable angina, NSTEMI, and STEMI? Before this, let's see the definition of myocardial infarction. The proper myocardial infarction definition is there should be one thing, that is there should be elevation of cardiac biomarkers. Mainly, we are talking about troponin. This is the preferred one nowadays, followed widely in NHS, and it is followed widely world over also. So troponin I should be elevated, one of the cardiac biomarkers, plus one of the following should be present. There might be symptoms of ischemia, like we discussed here. This symptom should be present, or there might be ECG changes, which we'll be talking. This is also ECG changes. There might be an echo changes, or it might be on the angiography what you're looking at. This we are not bothered much. Any one of this following can be present. We call it as in myocardial infarction. So how do we differentiate each one of the categories what we have discussed here? Unstable angina. In unstable angina, you'll have all the symptoms, or one of the following symptoms. Classical symptoms will be present, but troponin will be negative. It will not be positive, it will be negative. That is, cardiac biomarker will be negative. In NSTEMI, there will be no typical ECG changes. What do I mean by typical ECG changes? There is no ST segment elevation of more than 2 mm, which we'll be discussing in coming up slides. Again, there will be no typical ECG changes, or there will be no left bundle branch block. These two findings will be absent. There might be atypical ECG findings, but troponin I will be positive. Coming to the last one here, you'll be having typical ECG findings, that is ST segment elevation will be there, or there might be, and there might be left bundle branch block. This helps us to differentiate between unstable angina and STEMI. Now we need to differentiate between unstable angina and stable angina. What's the difference between unstable angina and stable angina? In unstable angina, there is a difference compared to stable angina. The main thing is, in stable angina, symptoms usually appear on exertion. That means when he walks for a certain distance, he starts getting chest pain and he becomes breathless. Once he takes rest, all these symptoms subside. Then we call it unstable angina. Unstable angina is similar symptoms, but now they are appearing at rest. Or now he's walking for 100 meters, he started having the symptoms, but he's taking rest, the symptoms are not going away. That means it is an unstable angina. So that's the difference. Symptoms go away when taking rest, and on only exertion symptoms appear, then we call it as a stable angina. There are two special kinds of anginas, which is known as Prince-Metal angina and decubitus angina. Prince-Metal angina is basically coronary vasospasm that results in a transient, a brief time of chest pain. And at that point of time, if you take an ECG, it will show ST segment elevation. But once this spasm disappears, the patient will be completely normal. For example, in cocaine, this might be the scenario where there is coronary vasospasm, and at that point of time, he might have chest pain along with the ECG changes if you take the ECG at that point of time. What is decubitus angina? Decubitus angina usually seen in patients who have severe cardiac failure. They are in heart failure, congestive cardiac heart failure, because of severe coronary artery diseases. So now and then they keep getting this angina, keep getting this pain that is known as decubitus angina. These are two separate kinds of angina which doesn't fit in stable or unstable kind of angina. Okay, so you need to be aware of the difference between unstable, NSTEMI, and STEMI. So we have already seen the exact definition of myocardial infarction. From exam point of view, they'll not test you on this. They will test you on this definition, that is the ECG criteria. Before coming to this, there are two kinds of myocardial infarctions. There is type 1 and type 2. Type 1 is the most commonly seen one. 99% of it will be type 1, where the primary cause or primary insult will be on the coronary artery. In the coronary artery, you might see a plug, or there might be a rupture of the coronary artery. This has caused acute myocardial infarction. What is type 2? Type 2 is basically there is decreased oxygen supply to the cardiac muscle. There is oxygen supply to the cardiac muscle is decreased. It might be because of severe anemia. For example, if the hemoglobin levels are in 2, 3, there is no hemoglobin, there is no enough RBCs to carry the oxygen to the myocardial muscle. That might cause. Or coronary spasms, which is seen in cocaine, as we discussed previously, like Prince-Metal angina. That is another type 2. Or if the patient is having arrhythmia, the cardiac output might be so less that there is hardly any supply to the coronary artery. Severe hypertension or severe hypertension can also lead. These are all type 2 myocardial infarctions. Here, basically, you need to treat the underlying cause. You shouldn't treat it as a typical type 1 myocardial infarction where we get an angiography or we thrombolize, we give aspirin, because there is no thrombus, or there is no plug, or there is no clot in the coronary artery to give the blood thinning agent as we give in type 1. Only in type 2, only what you have to do is treat the underlying cause. If they have severe anemia, treat them with blood transfusion. That's what you need to do. But in exam, always remember, it is type 1 what they'll be testing on. Type 2, they're not worried because it's a very rare presentation. The rarer the thing, the rarer it will appear in the exam. The type 1, what they are looking for in your exam and what you will be doing for type 1. So we can't wait for all the blood investigations if the patient is having an acute myocardial infarction to satisfy the definition what we are having here. That's why what we look for, we look basically for the ECG. That's why ECG becomes that handy in emergency department. Anyone comes with a chest pain, we always get an ECG done for this particular reason. What we are looking for in ECG, is there an ST segment elevation of more than 2 mm, that is more than 2 small boxes in 2 consecutive chest leads? That is the V1, V2, what we are talking till V6. In this 2 consecutive chest leads, if it is ST segment is elevated more than 2 mm, then we consider it as an ST segment elevation MI. Or if there is more than 1 mm ST segment elevation in limblets, this is 1, 2, 3, or AVL, AVF, what we are talking about, or AVR. In this leads, if it is more than 1 mm in 2 consecutive limblets, then we consider as an ST segment elevation MI, and we proceed ahead with the treatment. As we are still continuing with an ST segment elevation MI, different ECGs will have will denominate or will represent different anatomical parts of the heart. This I was telling you initially in the first class of the ECG how it represents differently. So we need to have a careful look at the ECG and see where is the ST segment elevation. Is it in V1, V2 in the chest leads, or is it in lateral leads? Is it in inferior leads? How do we look at it? So if you see here, V1, V2 basically represents the septum. From V3, V4, V5, sometimes V2 also, it represents the anterior wall. V5, V6 represents the lateral wall. At the same time, you can see on the lateral side, there is AVL and 1. This is also represents an lateral side. Similarly, below the inferior part, the lower part inferior is represented by 2, 3 AVF. So this is the inferior part of the heart. This much you need to remember anatomically. So what we are seeing here is V1 to V4, whatever it is there, it is supplied or blood supply is by LAD. Whenever LAD is involved, you see an anterior wall MI. So what kind of questions appear in the exam? They will give you an ECG. For example, they will give you this kind of ECG and ask you to diagnose. You need to tell whether it is a septal wall or lateral wall or an inferior or an anterior or an anterior-lateral. Those kind of questions will appear. They'll ask whether it's an anterior wall MI, inferior wall MI, lateral wall MI, anterior septal wall MI. You need to diagnose depending on the ECG findings, the ST segment elevation, what you're looking at. You need to diagnose on those parameters. The other question which can they appear is they're just given an ECG. Then they will ask you which might be the culprit artery, which is the most likely culprit artery, which is the most likely artery which has an thrombus there. So for those kind of questions, this is the algorithm or this is the tabular form what you need to really look for, and it is very important from exam perspective. So whenever there is a left bundle branch block, what we have discussed in our ECG classes, think of an anterior segment involvement, the artery will be LAD. If it is V2 to V4 involvement, then it is again LAD, again it is an anterior wall. V1, V2, septum, as I discussed previously, is a septum. It's an LAD what is again involved. V1 to V4, it is extensive. V1 to V4, it is anterior septal because it includes all these leads what we are seeing here. Again, it is supplied by LAD. Lateral wall MI, that is the lateral side, V5, V6, 1 AVL, that is a lateral wall MI. Left circumferential artery is more common compared to LAD. What do I mean? Or how do you, if both these answers are given, for example, one option is given as LCX, another option is given as LAD, then choose LCX over LAD. For example, LCX is not given at all. They're just given LAD and they are given RCA, some other options like that. Then you can choose LAD. If LCX is given, always choose LCX. Next one we are coming is anterolateral or extensive anterior wall MI. Here you will be having extensive chest leads involvement along with the lateral wall 1 and AVL also is involved. V5 and V6 also involved. So lateral wall leads are also involved. Here, either the thrombus or the emboli or the plug is in proximal LAD. That means very at the root of the LAD itself, the block is, or there are two arteries involved. One is LAD and another one is left circumferential artery. Most of the time when the patient presents acutely to the emergency department, it will be the single artery which is usually involved. So it will be most of the time it will be proximal LAD. Remember that these are the patients who go into cardiac arrest and it becomes difficult to revive them because there is an extensive involvement of the heart. Most of the left ventricle is involved. So most of the cardiac output is gone. So there is no cardiac output. So there is no pulse and this patient becomes very difficult to be resuscitated. Next comes is inferior wall MI. As described here, you can see 3 AVF, 2, 3 AVF are the leads which are involved. Right, RCA, right coronary artery, is more common than left circumferential artery here. This has basically two different types. Inferior wall MI can be an right ventricle involvement or an posterior wall MI. How do we differentiate this? In an inferior wall MI, if the patient has an hypotension or you're taken an V4R. What do you mean by V4R? This fourth lead is placed on the left side of the chest. If you place exactly opposite in the right side of the chest and do an ECG, if you see an XT segment elevation in V4R, then we call it right ventricular involvement is there. The artery is RCA. If there is a depression in V1, V2 or V3, also you can take it V3, then we consider most likely it is a posterior wall MI this patient is having. Most likely it is an RCA, more common compared to left circumferential artery. These two things we have already discussed. That is De Ventus syndrome. He's a famous cardiologist who has gone across and seen the anterior wall MI. These changes we have already discussed. It is an LAD occlusion. Wellen syndrome again represents an anterior wall MI. It's basically LAD stenosis, stiffening of the artery. Whenever there is an increased demand by the heart, it is not able to supply because this coronary artery can't dilate because it is stiffened. There might be calcium deposit in the walls of the coronary. That's why it is not getting dilated. Hence, there is no blood supply at all. So this becomes the description. Now we need to see, or we need to recognize very fast within 15 to 20 seconds that which ECG represents which part of the heart and which is the artery likely involvement. How do you look at an ECG? When you're looking at an ECG, for example, if you see an XT segment elevation in 2, then the next should be 3 and next should be AVF. So you need to look out for these 3 things together that represents inferior wall. Don't look at 1 AVR, V1, V4. Don't go in this pattern and then again in this pattern. Go in this pattern. 2, 3 AVF should be seen together. V5, V6 and 1 and AVL should be seen together. Rest of the artery, that is V1, rest of the leads, V1, V2, V3 and V4 should be seen together. Because this represents anterior, this represents lateral, this represents inferior. If you see the ECG in that way, you will recognize and pick up very fast. Once you pick up very fast, you know which part of the heart is involved and which artery is likely to be involved. So that will be the faster way to recognize in an examination. So let's see a few of the examples and try to recognize here. So we see an ST segment elevation in V2, V3, V4, V5, not much. So these 3 leads basically represents an anterior wall MI. So it is most likely an LAD artery which is occluded.
Excuse me, sir. Someone is removing me repeatedly. Why it is happening?
That's a moderator. Whenever the moderator asks you your name and you're not entered with your name, that's
Sir,
when you will be removed.
I have already mentioned my name, but he's removing me again and again.
Again, if you're in 2 devices, you will be removed.
I'm only in my laptop. He's telling me you are in 2 devices.
Yes, if you're
now
on
I
2
unlock
devices,
from my mobile. He removed me
you
from
need
laptop.
to be either on the mobile or on the laptop. If you're on
no,
2
sir,
devices,
I
you're
was
logging
just
in.
only in one device. He's removing me again and again. Please
Okay, I'll inform. If there are two devices we are removing, that's what I got the information. If
No,
it is
I'm just
not in
in
the
one
two
device.
devices, we'll
I
make sure
think
you're
in,
in.
by Dr. Noor, there is another person as well. He's thinking that's me as well.
We have only one student with Mohammed Noor. There are no two students.
No, I told him I just Dr. Noor. I think there is another person, Dr. Noor as well.
There is no another person. There's only one person. Okay, please log in with your one device and please don't interrupt the class. The moderator is there to help you out. Coming to the ECG pattern, sorry for the delay. Here, what we are seeing, where we are seeing the ST segment elevations. We can see ST segment elevation in one AVL predominantly, not seen much here in V5, V6. One AVL, V5, V6, though it is not seen here predominantly, one AVL is involved, so it is a lateral wall MI. Most likely it is an LCX involvement, that is left circumferential artery involvement. Let's see another ECG. What we are seeing here, there is an ST segment elevation in V2, V3, V4, V5, V6. So from here to here, there is an ST segment elevation. Along with it, we are also seeing an ST segment elevation in one and AVL. This is an extensive anterior wall MI, also known as anterior lateral wall MI. So most likely this is an proximal LAD which is involved. Choose LAD as an option that is most likely to be involved than LAD plus LCX. This is a rare thing to happen. LCX never will cause an extensive anterior lateral wall MI or sorry, it will never cause an extensive anterior lateral wall MI with the involvement only of LCX. So LCX will be the wrong answer here. What we are seeing here we are seeing an ST segment elevation in 2-3 AVF. This is an inferior wall MI. Remember that in the inferior wall MI, there might be reciprocal changes in lateral leads. What do I mean by reciprocal changes? There might be ST segment depression with T-way inversion can be seen in lateral leads. That is one AVL and V5, V6. You might see, sorry, you might see ST segment depression in this leads. Similarly, if you see an lateral wall MI, there might be, if you see here, there is a lateral wall MI, there might be reciprocal changes in inferior leads. Here you can see ST segment depressions, you can see in 3 and AVF. Those are the reciprocal changes. These are only seen in inferior or lateral wall MI. It is reciprocal. I mean, it is vice versa. That means if you see an ST segment elevation in inferior wall, then you will be seeing reciprocal changes in lateral wall. If you see an ST segment elevation in lateral wall, then you will be seeing reciprocal, that is ST segment depression in inferior wall. This doesn't hold good for anterior. It doesn't correlate with anything else. Reciprocal changes are only seen in lateral or inferior wall MI. Few more things before I give you time to ask question is inferior wall MI. How do you differentiate between an right ventricle and posterior wall MI? So inferior wall MI can be an right ventricular MI or posterior wall MI. Usually posterior wall MI, there will be ST segment depression in V1, V2, V3. We confirm it, ST segment depression is seen, and we confirm it by getting few more leads. That is, we are getting in V7, V8, V9. That exactly goes behind your body. That means you are getting one more chest lead done here, V7, V8, V9. So it represents the posterior wall. So you'll be seeing ST segment elevation at this segments. Next thing, if you are going across and we are seeing how to rule out and how to assume it is a right ventricular. If someone with an inferior wall MI comes with low blood pressure, that is hypotension, think of right ventricular involvement. This is mainly because what happens is if the right ventricle, this is involved, you're getting the blood from all over the body into the right atria. That is from superior vena cava and inferior vena cava, you're getting the blood into right atria. From right atria, it is going into right ventricle. So right ventricle, there is an infarction and not able to pump. That's the reason there's no blood going into left atria or there's no blood into the left ventricle. So no cardiac output. What we do here, this causes low blood pressure. This is the pathophysiology behind low blood pressure in right ventricular involvement. So as this right ventricle is not able to pump the fluid into the lungs, what we do is we give more and more fluid, so the preload increases. That means the blood what is coming into the right ventricle increases, and it kind of passively goes into the lungs, where it gets oxygenated, comes into the left atria, then left ventricle, then the blood supply is restored to rest of the body. So the treatment per se here is give fluids. Never ever give any inotropes here, only give fluids. So if you're an inferior wall MI with hypotension, it comes, think of right ventricular involvement, and if the hypotension persists, treat it with fluids. Again, you can confirm this by getting an V4R, that is right side one. So if you go here, we have taken an V4R and there is an ST segment elevation plus 2,3 AVF, there is an ST segment elevation. That's why this is a right ventricular involvement. If you go behind here, we said it is an inferior wall, but if you see in V1, V2, as well as slightly in V3, this is ST segment depression. So we can assume that there is a posterior wall involvement. This is an inferior wall MI with posterior involvement. This is an inferior wall MI with a right ventricular involvement. So these are the important things what you need to remember and how to come across the ECGs. This ECG we have already seen previously in ECG classes. Anyone wish to answer which ECG is this, or what is the pattern what we are seeing? ST segment depression with tall peaked T waves.
D winter.
Good.
D winter T wave.
It's a D venters. This is basically LAD occlusion what we are seeing. Here what we are seeing is ST segment elevation with T wave inversion, or we call it as in biphasic T waves. These biphasic T waves, what we look out for in V2, V3, if they are present, it is an Winters. It is an Valence syndrome what we are looking for here. There's another type of Valence syndrome where there's deep inverted T waves. This is also an Valence syndrome. Valence syndrome represents basically stenosis of the coronary artery, LAD stenosis what we have. The treatment remains same. For all this, the treatment remains the same. There is no changes in the treatment per se at all. Anyone has any doubts still here can ask me. This is important topic. Everyone should be aware from exam point of view as well as from your regular practice. Both are very important.
Sir, the inferior wall MI image, whatever is given, in that the reciprocal changes can be there in the lateral leads, no sir? But here it is showing V5 and V6 ST elevation, not this image. So, before that, yeah. So this is, yeah.
Usually we see reciprocal changes, but sometimes there might be this a non-specific ST segment elevation. If you really count here, there is only 1 mm of elevation. We look for more than 1 mm of elevation. This usually tends to happen when there is an posterior wall involvement, where there is ST segment depressions are seen.
Okay, sir.
Sir, what is the cause for the reciprocal changes, sir?
It's basically the electrical activity what is happening. The lateral and the inferior are kind of opposite to each other in the anatomical position. If you go across to the hot positions here, they're kind of opposite. So you're seeing the lateral here, inferior here. So they're kind of opposite to each other. That's the reason you see the reciprocal changes.
Okay, sir.
Doctor, but reciprocal change should be depression, صح? If elevation will not see reciprocal change.
Depression, reciprocal, we don't see ST segment elevation at all. If there is an elevation, the cardiac muscle is dying, basically. It's going into infarction. The blood supply is reduced to that part of heart if there is ST segment elevation, and it is an acute thing which is happening. That's why from emergency point of view, it is very important. If there is an ST segment depression, it might be an ischemia what is happening, not an infarction. There is a difference between infarction and an ischemia.
Dr. Amin?
Yes, please.
If there is inferior MI, ST elevation in lead 2-3 AVF, as well as there is a right ventricular ST elevation, V4 ST elevation. If there is 2 stem in the exam, which one we will select?
What are the two options?
Suppose inferior MI and right ventricular MI, both in the stem, separate
It will
stem.
be, then you should go for right ventricular MI because you're more specific, you're specifying more to the anatomical region. Because inferior wall MI can be an posterior wall MI, or it can be an right ventricular involvement. So you need to be more specific. The more specific you answer, you get the mark.
So we'll choose right ventricle. It
Yes.
is true as well as for posterior MI also.
Yes.
Okay, thank you.
Answer the Whelan syndrome type 1 will be biphasic T wave and second is deep inverted, right? Answer.
We are not worried about type 1 or type 2. If you just
Okay.
remember it as an Whelan syndrome, that is enough because the management remains the same.
Okay, sir.
Sir,
Dr.
in
Ami?
medicine,
please.
it says
Yes.
V3 and
I
V4
wa- I wa-
represent the septum.
One of you at a time, please. It got
Okay, I
muffled.
wanted to ask.
Yes.
I wanted to ask in the situation where you have elevation in 2, 3, and AVF, but 3 is greater than 2. So do we call that right coronary artery involvement?
2, 3 AVF you're talking about, right? It is an inferior wall
Yes.
MI what you're talking about. It will be
Yes, but
right
three-
coronary artery
three-
involvement.
Okay, 3 greater than 2.
It doesn't matter in which the ST segment elevation is much appreciated. Well, if it's appreciated in any artery, it doesn't matter. Here,
Okay.
in any lead, if you see an ST segment elevation, here you can see 2, 3. It can be an RCA or LCX. RCA is more common than LCX. Doesn't matter which one has a more ST segment elevation. We're just seeing a group of leads which has an ST segment elevation.
Okay.
Sorry, sir. It says V3 and V4 represent the septum, but RCM says it's V1 and V2. So which one is
We
actually?
stick to V1 and V2. It represents the septum. If you see, if you properly see, if you see in the 3-dimensional heart, the septal part is closer to the chest. That's where V1, V2 comes. It's closer to the sternum. So V1, V2 is the way you place these leads. That's where the septum comes and it represents exactly those leads. So stick to V1, V2. V3, V4, we go for anterior wall MI.
Doctor, I mean, what about the inferior wall MI? How can you give the fluid? How you give the fluid? How manage it?
See, you keep giving fluids till the blood pressure increases, unless there are any other contraindications. For example, please mute so that it doesn't disturb others. Okay. How much fluid to give? It's a good question. What we usually do is we give 250 ml of boluses and see whether the blood pressure increases. We keep giving this boluses and monitoring with an ultrasound. What we are looking through an ultrasound is inferior vena cava. Inferior vena cava, we are looking if it is distended and non-compressible or compressible. If it is compressible, we can keep giving 250 boluses till the blood pressure increases. If it is non-compressible and it is distended, that means there is already adequate fluid. If you give more, this patient will go in fluid overload. That's when you will stop giving fluids. Then you will think about starting on inotropes. Otherwise, you will not start on inotropes until IVC is completely distended and it is non-compressible. Again, it is kind of similar logic what we use it in sepsis and fluid resuscitation. In detail, we'll be talking in sepsis chapter. That is basically an infection chapter. We'll be discussing about the fluid resuscitation in detail. But remember that you'll be giving small boluses of 250 and we'll be monitoring with ultrasound.
Doctor, I mean, give
Yes, please.
go through angiography before the fluid or give fluid after that. We send it to angiography.
We send it as soon as possible. Fluid can be ongoing. You can just connect it and shift to the angiography. There shouldn't be any delay. The time lost, 1 minute lost, you will lose so many muscle fibers there, and which will be irreversible damage. So the sooner you transport to the cath lab and sooner you open the artery, the prognosis will be better.
Sir, why we need giving fluid in the inferior wall MI? Why patient is need like another we don't need?
because his question, if I'm not wrong, is in inferior wall MI, basically where the right ventricle is involved. Why do we give fluids and why don't we give fluids if left ventricle is involved? That is mainly involved in anterior wall MI. In inferior wall MI, what we are assuming is right ventricle is involved. In both, this hypotension can happen. But here, hypotension, we don't give fluids. Fluids are contraindicated. Here, we give fluids. We don't give any inotropes. Here for hypotension, we give inotropes. Usually noradrenaline is the preferred one. Sometimes, depending on the cardiologist, they can use dobutamine also. Depends on the cardiologist, but most of the literature says non-adrenaline, you need to use it. Why is it fluids here? And why is it inotropes here? There is a physiology which changes. You need to be good with your physiology. There is preload and there is an afterload, what we need to learn, and there is a contractility, what you need to look out for. What happens in left ventricle is the left ventricular contractility is lost. It is not able to compress, so the blood goes to different parts of the body. And it has to compress with certain pressure so that the blood goes to different parts of the body. Otherwise, it can't go to the different parts of the body. Okay, that's why we start on inotropes. In this case, if you give fluids, it will result in pulmonary edema, he will get shortness of breath, then you might have to intubate him. So it will be a disaster if you give fluids here. In right ventricle, the preload is affected. What do I mean by preload? The fluid which is coming to the left ventricle. We're just worried about left ventricle. We're not worried about the right ventricle, because left ventricle is the one which determines the blood supply to different parts of the body. The amount of blood coming to the left ventricle is reduced. So we need to increase the amount of blood coming to the left ventricle. How can we increase this? Because increasing the contractility of the left ventricle will not help, because there is not much blood coming into the left ventricle itself. How can we increase the blood into the left ventricle? Increase the volume of the blood itself. If the whole body volume of the blood is 5 liters, increase it to 6 liters. So the amount of blood which is coming is 300 ml. Now it will be increased to 400 ml. With the little bit contractility what the right ventricle is having, it will increase it. That's the reason you give fluids in right ventricle, not the inotropes. That's the differentiation between right ventricle and left ventricle infarction and failure, how we treat it during acute scenarios.
Sir,
So
I think Starling law. Sir, I think this is the Starling law. Preload.
Yes, there is a Stirling law also. You can increase it to certain point. That is this diagram what you have learned. So it increases to certain point till you give the fluid, then it starts dipping in with the left ejection fraction. Stirling law is mainly related to the left ventricular ejection fraction. Here the Stirling law applies, as you're telling. So we tend to improve the preload by giving the fluids, and we are going to the optimum position in the Frank-Stirling curve. That's what, again, MRCM primary hot question it is. All of you must have learned that one there. So it's basically, we are getting into the physiology part. So we have done with this ECGs. Now we are getting into more how to diagnose it. We know it. What's the treatment? Before we enter into the treatment, it becomes difficult to diagnose if the patient is having an left bundle branch block or the patient is having a paced rhythm. This is the paced rhythm where you're seeing an electrical activity as in line in front of every QRS complex. When this happens, then we call it as an paced rhythm. In paced rhythm, we can see there isn't some ST segment elevation. Can we consider this as an ST segment elevation and label it as an anterior valve landmark? No. There is a rule what you need to follow that is known as Sarbo's criteria. Do you need to remember? Do I need to remember this criteria? No, not required. But you need to remember the name. There is a criteria for any patient who is a known case of LBBB. Known case, not a new LBBB. He is a known case of LBBB, or he is known to have a pacemaker. Then we follow a criteria known as Sarbo's criteria. The previous thing what we learned doesn't hold good here. Here you need to follow Sarbo's criteria. You need not remember this Sarbo's criteria. This is only for your reference purpose I have put up here. You just have to remember there is a criteria known as Sarbo's criteria, or it is also known as Sarbosa criteria. We send every patient who comes to emergency department and hasn't chest pain, gets an ECG done and sends for TROP-I. TROP-I is basically an biomarker. Right over the NHS, nowhere they're following CKMB, which is a little bit non-specific. They don't want, it takes a little bit more time to elevate in the blood. What they are preferring is troponin I, preferably, if not troponin T. Troponin T is also getting exhausted. Troponin I is more specific one. This peak differs from labs to labs. You need to go through the test, how sensitive it is, how can it pick up, and how many days, in how many hours it picks up. So each NHS trust has its own criteria. They will not test on this parameter. If you see your OHM, or if you go through the OHM, that is Oxford Handbook, what they have said, or most of the EDs in UK, what they are doing is they get one TROP-I done immediately once they enter the emergency department. Another TROP-I, they do it after 3 hours and check. If there is an increase in value of 20% or more than 20%, they consider it as an MI. There is one more protocol they follow. They basically wait for 6 hours to send for cardiac enzyme, then see. Because if you do it, if the patient comes, I'm having this chest pain since last 5 minutes. If you do a biomarker, that is troponin I, it will not be elevated. So there is no point in getting a troponin I done immediately unless you're following this criteria. You get in baseline, after 3 hours, do it again. If there is an increase in 20%, then yes, he is having an myocardial infarction. That is NSTEMI, what we are talking about here. STEMI is only based on ECG. Then we shift them to the cath lab. What is the treatment? What does the NICE guidelines say treatment? There is difference between treatment for STEMI, that is ST segment elevation MI, and versus compared to non-ST segment elevation MI. Okay, this is directly picked up from the NICE guidelines. What I want you to learn is this one. This is nothing but the same thing. It is more clear what you need to know from emergency point of view and from exam point of view. This includes much more which goes in, which stent to use, how to revascularize, which route to be preferred, whether it's a radial or whether it's a femoral. It's much, it is more for the cardiologist than for the emergency physician. What is required from emergency point of view, we have put up in this tabular form. So any patient who has an ST segment elevation MI diagnosed on ECG gets an aspirin 300 mg stat. So bolus 300 mg stat, you will be giving per oral. If you're not able to give it per oral, then you might have to put an nasogastric tube and give it. Sometimes they might even give it per rectal also, but the preferred one will be nasogastric tube, or per oral you are giving it if he's able to swallow. Next thing, in rarest of the rarest condition, it might be contraindicated for an reperfusion therapy. What are the rarest thing? One thing I can remember of, if a patient is on palliative treatment, for example, he is known case of CA lungs, he's in stage 4, he's on palliative care. So no point in giving a reperfusion therapy for that patient. That's when we do a medical management. This is the medical management. But they will not test you on this parameter. They will test you on the reperfusion therapy. This is where they will test you. This is where it is very important for you to remember each and every point. First and foremost, or first important or first priority should be given for angiography, followed by insertion of a stent. Okay, that is percutaneous intervention. They call it a general term. That is basically angiography followed by angioplasty, what we are talking about. Any patient who presents within 12 hours of onset of chest pain, or there is an ongoing chest pain, continuing chest pain he is having, the symptoms are continuing even after 12 hours, he has presented even after 12 hours, and the chest pain is continuing, then if you're able to deliver angiography within 120 minutes, then he should get an angiography within 120 minutes. That is, it is within 120 minutes he needs to get it. You need to shift this patient to cath lab within 120 minutes from the time he has entered the emergency department. If you are not able to do that, that's when you try to do an fibrinolysis, thrombolysis, fibrinolysis. Again, this patient should be presented within 12 hours of the symptoms, and percutaneous intervention is not possible within 120 minutes. What we do here is we use thrombolytic agents. Preferred one is tenecteplase. You need not remember, it depends on hospital to trust, hospital to hospital. Some hospitals might prefer alteplase, some hospital might prefer tenecteplase, where the dose is 0.5 mg per kg. Again, you need not remember the drug name, you need not remember the dose. You just have to remember fibrinolysis you need to do. It can be done with alteplase, tenecteplase, or any other thrombolytic agent. Along with it, same time, you'll be giving an antithrombin, preferably fondaparinux. It changes, the dose changes from weight to weight. Need not remember the dosage here. After giving thrombolysis, you will wait for 1 hour's time and repeat an ECG. If and repeat ECG, the ECG changes have resolved. What do I mean by resolved? There were ST segment elevation in inferior leads, that is 2, 3 AVF. There were ST segment elevation. Assume that they were, and then you will repeat after 1 hour. When you repeat it, this ST segment elevations are gone. They are no more. It has come back to the normal baseline. Then you need to continue managing this patient in your hospital itself. You repeat the ECG, but still persistent ST segment elevation are there. Then you shift this patient to nearest cath lab as soon as possible, so he gets an immediate angiography done. Don't repeat the fibrinolysis. Don't give one more dose of tenecteplase. Never do that. Then they have not tested till now, since last 10 years also, if you see the recall questions, they have never tested on the antiplatelets what needs to be given, but it is good to remember which antiplatelets needs to be given. You are given aspirin here, so everyone gets an aspirin. If he is not on any oral anticoagulant, then you give prasogil for the patients who satisfy this criteria. If he is on any oral anticoagulant, for example, he is on rivaroxaban, then give clopidogrel along with the aspirin. What about if you're planning to give an fibrinolysis? What are the antiplatelets addition to the aspirin you're giving? Ticagrelol if there is no high risk for bleeding, clopidogrel if there is high risk for bleeding. This is the same thing holds good for medical management also. This is the same thing which holds good for NSTEMI management also. Now we are entering into an NSTEMI is same as that as an unstable angina. Both of these are treated in a similar manner. So what we'll do, any patient who comes with an elevated cardiac enzyme, that is NSTEMI, and no specific ST segment changes, which is suggestive of ST segment elevation MI, or any patient who comes with typical cardiac chest pain, which is persistent, but cardiac enzymes are negative, and there are no ST segment elevation changes on ECG, these patients, all of them get an aspirin and get an fondaparinux. Okay, this is an antithrombin fondaparinux. Unless they are high risk for bleeding, then you'll not give fondaparinux. But everyone gets, irrespective of risk for bleeding, gets an aspirin. Okay, then you do an gray score. Gray score is a complicated score. What we do is, this is done in ED, then we usually admit under acute medicine. This acute medicine people, what they do is they do an gray scoring. If gray scoring is low risk, this basically predicts the morbidity and mortality. If there is a low morbidity and mortality, then medical management is done. This is quite similar to what we learned in fibrinolysis, the platelets, what we are giving. If the patient is intermittent to high risk and unstable, what do I mean by unstable? He is requiring oxygen. His blood pressure is borderline on the lower side. He's having tachypnea. Those patients get immediate angiography, because you need to open the artery. This patient is unstable. He might throw up any arrhythmias any point of time and go into cardiac arrest. So do an immediate angiography. If this patient is stable, then we usually recommend doing an angiography within 72 hours. That is next 3 days. We arrange an angiography and get it done. It doesn't require an immediate one, but requires in next 3 days. So this is the management for NSTEMI or unstable angina. If you remember this much, this is more than enough from exam point of view. You need not go through this complete guidelines. It is a perfectly summarized one, which will be more than enough for the exam. These are the two treatments. If anyone has any doubts regarding the treatment, can ask me questions now before we get into orbit score.
Assalamu alaikum, sir.
Walaikum salam.
That you saw that clopidogrel, there is no risk of bleeding. So how do you know that there is high risk and low risk? How to know?
That is depending on the orbit score. That's what I'll be discussing next.
Okay.
Dr. Amin, what about the Barcelona criteria for LABB?
Sorry, what about?
Barcelona criteria for bundle branch block.
We will treat left bundle branch block, you will treat it as an STEMI. It is equal to STEMI. This one is left bundle branch. So ECG changes. What are the ECG changes? If we go back to our slide here, the ECG changes where we consider as an STEMI or this changes. Any new onset LBBB or ST segment elevation in limb or chest leads, what we have discussed. These are all together or STEMI, and the treatment remains the same. No changes in the treatment.
Doctor, if the patient have a contraindication to use aspirin, also we still giving the aspirin?
It depends on what contraindication you have. If the contraindication is gastritis, then you go ahead and give it, simple as gastritis. If it is like for aspirin, the patient is having anaphylaxis, then we avoid it.
Like replaced by another patient or?
No, aspirin is the only antiplatelet drug which is proven to reduce the morbidity and mortality. Okay. That is one more important thing. Out of all this medical management, what we are doing, only one thing which is proven to reduce the morbidity and mortality is only aspirin. Remember that. None of the antiplatelets drugs are known to reduce the mortality or morbidity. Only aspirin is proven. Coming to orbit score help us to classify here and all. I keep on telling that no high risk for bleeding. So if someone is low to intermediate risk, we tend to give the antiplatelet ticagrelor in STEMI. We tend to give clopidogrel if they're high risk to bleeding, depending on the orbit score, what we're looking out for. Orbit is a mnemonic where O stands for older age, that is 74 years or older than 74 years. R stands for reduced hemoglobin levels, that is anemia. It depends for males and females, the normal range changes, and from lab to lab, the normal range changes. If it is less than the normal range, then we consider as an anemia, and those patients get 1 mark. Any bleeding, history of GI bleed or intracranial bleed or hemorrhagic stroke, any point of in his lifetime, if he had, he again gets 1 point for that one. Any reduced renal function, that is insufficient kidney functions, GFR less than 60, we give it 1 mark. They are already on an antiplatelet, for example, a clopidogrel or any other drug, again, they get an 1 mark. So altogether, this is known as orbit. Depending on the score, anyone who has 4 or more than 4 is considered as an high risk. And high risk, depending on this algorithm, here usually we tend to give clopidogrel. In NSTEMI, also we tend to give clopidogrel. In NSTEMI, mainly we are talking about the anticoagulants here during angiography. Otherwise, it remains the same. There are no changes. You need to just remember once, it's the same thing you can apply for medical management with STEMI. If there is a contraindication, same thing applies when you are using fibrinolysis. Only the change during angiography, it changes where you give prasugrel. So we're getting into complications here. Complications you need to remember, because why I need to know complications. If someone comes with a myocardial infarction, you need to be aware of these complications, because he can have this complication any point of time and you can intervene immediately. Left ventricular failure will cause accumulation of the blood in the arteries in the lungs. So basically, if you consider this as lung, if you take a part of this lung and expand it, these are the alveoli, what you're talking about. Surrounding the alveoli, there are capillaries which are running. If left ventricle fails, it is not able to pump the blood at all this blood gets accumulated in this artery and they get distended. They're filled with the blood here. Whenever they're filled with lot amount of blood or any fluid in a container, if you increase it, the hydrostatic pressure increases. If the hydrostatic pressure increases, it tends to move from the artery into the interstitial fluid that is surrounding the alveoli, and this alveoli collapses. That's when the patient tends to have breathing difficulty. This is nothing but pulmonary edema. So anyone who has a left ventricular failure, you need to suspect in an anterior wall MI. Anterior wall MI, shortness of breath, suspect pulmonary edema. This is the pathophysiology, what is happening. Anterior wall MI, left ventricular failure, and the failure is so severe that it is not able to pump enough blood to maintain the blood pressure. Then we call it as a shock. Shock, basically, very vague term, is systolic blood pressure less than 90. Right ventricular failure, we have already discussed, which is seen in inferior wall MI, shouldn't be a problem. We have already discussed. U fluids, remember that U fluids don't start inotropes in this. Mitral regurgitation, you can see here, there are papillary muscles here, and there is caudate, mainly the capillary muscles which are attached to the mitral wall. If the infarction is here, they might die and they may not pull or they may not close this mitral wall as it's supposed to do. That will cause mitral regurgitation. Okay, so you might have a murmur. Mitral regurgitation usually causes pansystolic murmur. This septum can rupture and result in an VSD. That is a communication between right and left ventricle resulting in mixing of the blood. This is basically ventricular septal rupture. The wall here can rupture and cause the fluid to accumulate in this space. That is nothing but pericardial space, resulting in pericardial effusion. If the amount of fluid which has gone into the pericardial space is very much more, it can cause cardiac tamponade. Any infarction in the ventricle or in the atria can be the place where electrical activity is generated, causing arrhythmias. It can be ventricular or supraventricular arrhythmias. If the conduction pathway is involved, it can cause conduction defects. Remember that conduction defects are commonly seen in inferior wall MI, because inferior wall MI is the where right part of the heart is involved. Right part of the heart is where SA node and AV nodes are present. That's why these nodes can get involved and can result in different blocks. This arrhythmia, especially ventricular arrhythmias, which we are mainly worried about, is usually seen in anterior wall MI. Okay, they can ask you questions like this. In inferior wall MI, which is the most common complication you can suspect, they might give different options. Conduction defects is the one. In an anterior wall MI, which is the most common complication you can suspect, that is ventricular arrhythmias. This is important. Remember, in that way, it will help you. Till now, we have discussed about acute myocardial infarction where there is an infarction happening. Someone comes with an atypical chest pain. He says, yeah, I feel like some heaviness, it stays for a minute or two. Otherwise, I don't have any other symptoms. I'm a healthy person, I just smoke. What do you do with those kind of persons? Or how do you manage those kind of persons? That's when they have come up with something known as heart score. This heart score is very important. It is used widely in the NHS. In every pass there is a question which comes from the heart score. Heart score, you classify basically, it's a mnemonic itself, HEART stands for, where history, highly suspicious gets 2 points, moderate 1 and slightly suspicious 0. ECG, ST segment deviation or non-specific ST segment changes, normal gets 210. According to age, you get points. The risk factors is the when they really test you. The risk factors is the one they are testing you, you need to be really aware of. Next one is coming is troponin I, 3 times more than the normal limit, 1 to 3 times, between 1 to 3 times, or normal limit again gets 210, and you classify as, depending on this, you discharge them or admit them or get an immediate angiography, depending on the scoring what you are getting. What they are really testing you is on the risk factors. You need to be aware of all the risk factors. That's the reason we have modified. This is not there in previous any classes. We have got in depth so that you know exactly what are the risk factors. Hypertension is one risk factor. High cholesterol levels, it can be any cholesterol. It can be triglycerides or low, it can be triglycerides or high density, anything, HDL, LDL. Mainly we're talking about LDL and triglycerides we're talking about. If these are high, we call it as an hypercholesterolemia, and these patients are having one risk factor. They can be diabetic, obese. The BMI is important. They should be more than 30. Smoking, they might be a current smoker or cessation within last 3 months. If they're ceased, again, they is considered as a high risk. Positive family history. This is where they tested in the last diet. Okay, parents or siblings with an cerebrovascular disease before the age of 65. They had given it as in 75. It was not a risk factor. Okay, so age, you need to remember that should be below 65 years. Above 65 years, because of the age they might have. If I'm 80 years old and I'm having an MI, I'm not a risk factor for my child. Okay, I'm not a risk factor for my sibling. After 65, it is kind of expected. Atherosclerotic disease, prior MI or any PCS, EABG, CA, CVA, I'll get back to you. Any TIA or any peripheral artery disease, again, it is a risk factor. CVA, if you go in depth, a hemorrhagic stroke is not a risk factor. Okay, ischemic stroke is a risk factor. Okay, if, for example, they have given all this, they have asked and they have given stroke and they asked you to pick it up. So all are correct. Stroke is also correct, but stroke, not all the strokes. Hemorrhagic stroke is not a risk factor. So select this option. If stroke is given at the same time, age is 75 or something more than 65 they are given, then choose this one. All these options are given, but BMI what they are given is 29, but BMI what they are given is 30, choose this option. So be careful, they're testing on the risk factors. You need to be thorough with the risk factors. This is very important. It can appear again in the exam and they can test you on different risk factors. They want you to be aware of these risk factors because when you're taking history, you need to collect this. You can't open your mobile and look out for these risk factors. Why they are not testing on other parameters? Because you can go back and look into your mobile while you're typing the notes and look out for the further risk factors. These factors you need to be aware, because in front of the patient, you can't open your device. If you open your device, they don't want you to see him. They will think that you're not a good doctor. You don't know anything. That's the reason they want you to remember this risk factors. If anyone has any questions, can ask me now. This is very important.
Yes, Dr. Amin. Hello?
Yes. Yes, yes.
Yeah. If in exam, if the scenario is like that, that patient with chest pain has television MI and complicated with the failure, I mean bivasal crackles and dyspnea. If what is your initial management and definitive management? If there is oxygen, refer the patient to RR or furosemide, and so which one will you choose? Yeah.
You will always go, you are telling me a scenario where this patient is sick. So you will receive this patient in a resuscitation. Think about it. Imagine in real scenario what is happening. This patient is sick. You see him on the stretcher, you sick, he is breathing, he's gasping for the air. So what you will do, you'll take him in the resuscitation. What you will do, the first step, you'll look at the airway, you'll look at the breathing. You will not even ask him, you haven't chest pain. You look out at the airway, you look out at the breathing. His saturations are low in the breathing, you'll start him on the oxygen. So oxygen takes over everything else. Okay, then
even if there is aspirin also in a stem, will not.
You go for the oxygen.
Okay.
Okay. Oxygen, if you don't, one second. Oxygen, if you don't give oxygen, he might have an hypoxic cardiac arrest. You don't want an hypoxic cardiac arrest, this patient. First give him oxygen, then we'll come about to the aspirin and all. Yes, please. One more question was there.
Sir, hello.
Yes, please. I can hear you.
Sir, if a patient have typical symptoms, but the STL, there is no ECG changes and also the biomarkers also negative, can we go direct for angiography for investigation?
It's an unstable angina what you're talking about, because cardiac markers are negative and you are telling there are no ECG changes. Or if the cardiac marker is also positive, first what we'll be doing is giving an aspirin and fondaparinux, then we'll be doing an gray scope. For example, this patient who has come in an unstable angina and STEMI, and unstable he's having low blood pressure, or he's tachypneic or tachycardic, or something is unstable, then we'll plan for immediate angiography. So this answer is in this algorithm.
Thank you.
Sir, regarding the complications, in anterior wall MI, all these three can happen, right? Pulmonary edema, cardiogenic shock, and ventricular arrhythmia. Why
Yes.
this ventricular arrhythmia is most common? Like you told us that while choosing, the most common we are supposed to choose, right?
Yes.
So,
arrhythmias are more commoner, or it's found in left ventricle compared to that of the pulmonary edema. Arrhythmias, usually they tend to have PVCs coming up very fast if there is an anterior wall MI. This is mainly because if there is a small MI, small infarction also, this small infarcted site can be the place where the electrical activity can disrupt and start generating or start pacing from here. That's the reason arrhythmias are more common, what we say, in common. It is not the VT or VF what we are talking about. In general, we are talking about.
okay, sir. Thank you.
Can you explain about the hard score risk factor, about how complicated?
These are the risk factors. What was I talking about? Hard score. Mainly, they will be testing on the CVA, which is stroke, as they'll give an option. Okay, stroke is still the right answer. Then you need to check out if all other, they are given hypertension, they are given a patient with obesity more than 30, and family history who is just 59 years or less than 65 years basically, then you choose stroke as right answer. If stroke, along with stroke, they have given and someone, a sibling with 75 years old has a myocardial infarction, then you will not consider it as a risk factor. So this one becomes more right, and this one is not an risk. This is an risk factor at that point of time. So again, we'll be discussing in the questions. So they're slightly tricky in the risk factors. That's why I've taken time to explain you. Again, during questions, we'll get back to similar questions. These are the recall questions. We'll get back to you tomorrow in the class.
And sir, one, the difference between high sensitivity troponin I and the normal troponin I.
High sensitivity is basically it picks up much earlier in the blood. If it is a small quantity of I also it will pick up. Tropa is basically nothing but an biomarker which is released whenever there is an injury to the cardiac muscle. So cardiac muscle ruptures when there is a breakthrough in the cardiac muscle due to the injury of infarction. This gets released in the bloodstream, and it usually takes at least 3 hours time to appear. If your lab is or your test that is troponin I, high sensitivity troponin I, usually gets elevated or significant elevation is seen in 3 hours time. If it is high sensitive. If it is not high sensitive, it is around 6 hours what we are looking at, 4 to 6 hours it takes. Again, it depends from lab to lab, and who is manufacturing, all those parameters differ. So it differs from trust to trust. That's the reason they will not test you on that part in the exam.
Thank you.
Okay, we'll go ahead into inflammation now. Inflammation of different parts of the heart. So if you take a piece of the heart, and this represents that one, the outermost layer is pericardium, which has a pericardial cavity. The middle layer is nothing but muscle, which is known as myocardium. The innermost layer is nothing but endocardium. Okay, endocardium, most of the time inflammation is because of infection. That's why we call it as an infective endocarditis. Myocarditis is one of the most difficult diagnoses for anyone to diagnose, but there is an tricks what they use it to predict it might be a myocarditis. There is no specific test, or there is no single individual sign which will say the patient is having myocarditis. So each one of this we'll be discussing now. So pericarditis is nothing but inflammation of the pericardium. When you lean forward, your heart comes very much closer to that of the rib cage and sternum, and it kinds of lies over it. That's when your heart muscle gets friction over the pericardium, and the pain increases because it is already inflamed. Okay, that's why you see a pericardial friction rub also. When this patient lies backwards, it is not in friction or it is not rubbing any part of your body which is highly sensitive, and it is not rubbing the pericardium. That's why the patient feels better. So typical history will be on leaning forward, my pain increases. The pain is more pleuritic type of pain. I feel it is kind of pricking type or it kind of stabbing kind of pain I am having. And this pain becomes much better when I'm lying flat. That is the typical history. What I said now holds good for pericarditis. If you see RCM learning, they have said one of the most specific symptoms is pain radiating to the tricep ridge. That is pain radiating to your upper back is one of the most specific symptoms, but it is very rarely seen. That is also a problem. When this symptoms appears 2 to 3 weeks after an acute myocardial infarction, then we call it as a Dressler's syndrome. Okay, it should be at least 2 weeks after myocardial infarction. Then inflammation has occurred, then we call it as a Dressler's syndrome. The treatment remains NSAID, non-steroidal anti-inflammatory drugs is the treatment. Nowadays, in new literature, they have started selling, including in your RCM learning, they started suggesting that along with NSAID, use colchicine. But in exams, still they are stressing on NSAIDs. If they're given NSAID plus colchicine, choose that option. If colchicine is absent, still choose NSAID. It is not a must that you need to give colchicine. When do you admit this patient? If the patient is just having these typical pains, all other parameters are fine, you can discharge him. If the patient has high-grade fever, there is so much of pericardial effusion that it is causing compression of the ventricles, causing cardiac tamponade, then yes, you need to admit this patient because they have a large pleural pericardial effusion they are having. It's not pleural, this is pericardial effusion. They're not responding for the treatment. You're already given treatment, he has come back with same pains, is not responding. If they're immunocompromised, it's a traumatic cause for pericarditis, then you need to definitely admit. If these patients are on oral anticoagulants, then you need to admit. If this patient along with pericarditis has an myocarditis also, which is known as myopericarditis, you need to admit. I will tell you in coming up slide how to suspect an myocarditis. The typical finding, what you see on the ECG is concave ST segment elevation in widespread. So concave ST segment elevation, you see in all the lids. In all the lids, you are seeing ST segment elevation along with PR segment depression. A PR segment depression is seen here. So all the lids are having ST segment elevation with PR depression plus pleuritic chest pain, which gets better on leaning forwards, gets better on lying flat and gets worse on leaning forward, is a typical presentation. The diagnosis is pericarditis, treatment remains NSAIDs. Coming to myocarditis. Myocarditis, as I keep saying, there is no specific test to really diagnose it. What happens here? The cardiac muscle itself, this muscle itself is completely inflamed. Once it's completely inflamed, it can't pump to the optimum as we suspect it to pump. That's the reason this patient will go into heart failure. So any patient who comes with a viral prodrome, that means someone with had an upper respiratory tract infection or having an upper respiratory tract infection, present to the emergency department with an heart failure, then suspect myocarditis. Okay. What does the ECG says? No specific findings on ECG. What does the echo say? Echo will show that the whole myocardium, that is complete heart, it is not contracting with the optimum because of the inflammation. That is known as global hypokinesia. Because there is an inflammation of the cardiac muscle, there is injury to the cardiac muscle that results in increasing in troponin I. That is one more cause for increase in trop I. Trop I is not very much specific for myocardial infarction. This might be also the reason for increasing trop I. What is the treatment? Supportive treatment. There is no specific treatment what you can do here because it's just an inflammation. It's not an infection. Most of the time it is viral. Most common viral is Chagas disease, which causes it. So mainly supportive treatment. If he's in heart failure, treat it as in heart failure, which we'll be discussing at the end of the class. So mainly supportive management for myocarditis. What about infective endocarditis? As the word suggests, it is an infection. what is happening. Infection causes inflammation of the innermost layer of the heart, that is endocardium. This innermost layer also lines the walls. Okay, so we can see vegetations, we call it over this one. If you expand it, this is the vegetations. These vegetations can be seen on echo. Okay, so echo becomes very important in diagnosis of infective endocarditis. First of all, who are the patients who are predisposed to infective endocarditis? Who already have a prosthetic heart valve, who are IV drug abusers, or there is a previous history of infective endocarditis. These are all high risk for infective endocarditis. What are the common organisms you see? And these questions tend to come in most of the question banks, though they are not tested in the RCAM exams, but most of the question banks like to test you on this one. So it might be tested in the exam. The most commonest overall organism is Staph aureus. In IV drug abuser, again, it is Staph aureus itself. If the prosthetic valve which is implanted is more than 1 year old, so it's been implanted 2 years back, 3 years back, 10 years back, then Strep viridae is common. Any dental procedures, again, Strep viridans is the most common one. This is taken from RCM learning. Studies are also been done. This stands hold good. Okay. In your MRCM success, if you see, they just mentioned the dental procedures, they are not present about everything. We have collected everything. If they test you on anything, this tabular form should be sufficient to answer. What are the clinical features, or how do you suspect an infective endocarditis? In the stem of the question, look for new murmur. New murmur is mainly because of the vegetations, what you see on, on the walls. So there will be a new murmur on auscultation, what you'll be looking for. Along with this new murmur, there might be any immunological phenomena, vascular phenomena, or emboli, but there might be none. So an viral infection or in any infection with a new murmur, forget this one, a new murmur who presents to the emergency department with any immunological phenomena or vascular phenomena or emboli, always suspect an infective endocarditis. So this is an inflammation and it is an infection. So fever will be there. Murmur, I already told. There might be reduced appetite and weight loss because of the fever. You don't feel like having anything. Immunological phenomena are important. This is Osner's nodule, what you're seeing. Rot spots are nothing but hemorrhages seen on the retina while you do an fundoscope. This, what you're seeing, is vascular phenomena, Janway lesion. This, what you're seeing, is a sphincter hemorrhage, what you're seeing. As you see here in the previous slide here, these are the infective. This can embolize. These are known as infective emboli and can go to any part of the body and cause infarction. So it can cause pulmonary infarction, that is nothing but P. It can cause a stroke. It can go to your peripheral digits and cause infarction there. So digital ischemia in your fingers or toes. So those are the symptoms what you need to look out for. How do you diagnose? You diagnose depending on the Duke's criteria. It is not important to remember the Duke's criteria because most of these are the investigations which will be not available in the ED. For example, blood cultures are not available in the ED. So there is no point, or they'll not test you on Duke's criteria. So this is not important from emergency point of view. But you are suspecting from this symptoms, signs and symptoms, that it is an infective endocarditis. Then you need to collect blood cultures. This becomes important because you need to collect 3 samples of blood cultures here before you give an antibiotics, or at least 1 set of blood cultures should be collected before you collect antibiotics. These 3 sets of blood cultures should be taken from 3 different parts, 3 different sites. For example, 1 from left upper limb, 1 from left lower limb, like that. You need to take it from 3 different sites, 1 hour apart. So this has to start in the emergency department. So this thing you need to remember. If you miss it, it becomes difficult for the intensivist, or it becomes difficult for the acute medicine people to collect all the 3 samples because you're already given the antibiotic. So collect these cultures, at least 1 set cultures before you give the antibiotics. Use local protocols for antibiotic. You need not remember the antibiotic names. It's not required. It's according to the local protocol. They'll not test you. They might test you on the samples, blood culture. They might test you on the diagnosis. They might test you on the organisms. They might test you on the high risk factors for infective endocarditis. So this is the innermost layer. Coming to pericardial effusion. Pericardial effusion is basically there is an pericardial layer, inside that there is an cavity. To avoid the friction, there is an fluid which runs in the pericardial cavity. When this fluid increases, then we call it as an effusion. Various causes are there for the effusion. It might be traumatic, it might be infective, it might be due to the heart failure, or it might be due to the systemic diseases. Various amino acids, because of those things, systemic diseases can cause pericardial effusion. Pericardial effusion is different from that of the cardiac tamponade. When do we call it as a cardiac tamponade? If the patient is having a triad, we usually call it as an cardiac tamponade. What is the triad? What we are looking for? We're looking for the muffled heart sounds. We're looking for distended neck vessels. Okay. Another 1, 2. The third one is
Hypotension.
Hypotension. Yes. That's the reason this patient is unstable. Okay. Why do we get hypotension in this patient? If you consider this as an heart, this as an pericardial, this fluid will increase so much that this starts compressing on the ventricle. So during echo, if you see compression or collapsing of the right ventricle during the diastole, this is the most earliest finding for an cardiac tamponade on echo. So in FRCAM exam, they have tested what is the earliest finding where you see on an echo to call it as in cardiac tamponade. So right ventricular collapse during the diastole is the earliest echo finding for a cardiac tamponade. So this is the triad what you are looking for a cardiac tamponade. It is not same as pericardial effusion. Remember that if the fluid accumulation is low, even though if there is 1.5 liters of fluid which is accumulated in the pericardial space or pericardial cavity, it may not lead to cardiac tamponade. It doesn't depend on the amount of fluid. It depends on how soon the fluid has got accumulated. The sooner it got accumulated, the chances of cardiac tamponade will be that high. For example, a rupture of the ventricle and the blood gets oozed into the pericardial space, then it will cause pericardial tamponade. A traumatic rupture, then it will cause. So those causes are important. ECG findings are there. Few classical ECG findings are there. Tachycardia and low voltage is obviously seen. Low voltage mainly because if this is a heart, there is large amount of fluid which has gone on. This fluid will interfere with the electrical activity which is coming to the chest leads, which is over the chest or over the limbs. So the electrical activity is hampered by the fluid what is there. That's the reason the QRS complex voltage is small. This amplitude is small, you are seeing. Tachycardia is very obvious because this patient is going into hypotension. Electrical alterance is one of the things what you need to remember here. What is electrical alterance? You can see this amplitude and this amplitude is different. And this pattern is continuing here, here, and here. This is known as electrical alterance. Why does a patient have an electrical alterance? This is mainly because if this is an heart you're considering, this is in fluid. So heart can move around in the fluid. Sometimes it might be close to this part of the heart. Sometimes it might be close to this part of the chest. Sorry, not part of the heart, this part of the chest or this part of the chest. So it is moving. That is known as swinging sign. Okay, on the echo, that is known as swinging sign seen in large pericardial effusions. Because of swinging of the heart, you see a classical ECG finding known as electrical alterance. When this heart is closer here, the amplitude will be high. And it goes away from here, the amplitude becomes small because the electrical activity is also going away from it. So the changes in amplitude is seen. This is known as electrical alterance. So again, swinging of the heart, I have already explained to you. This is the echo picture which shows this black thing, what you're seeing here, the black thing, that is nothing but pericardial fluid. What you can see or really appreciate here is the right ventricle, which is getting collapsed. This is a classical echo finding for cardiac tamponade. So they can give you an image of an echo and ask you to diagnose. So first look out for the ventricles, look out for the myocardium. Surrounding the myocardium, is there any black color fluid? What you see here, this is the black color fluid. Yes, if you're seeing, then yes, it is an pericardial effusion. unless they are giving an GIF image, it will be difficult for you to diagnose whether it's a cardiac tamponade or not, unless they give a classical image. What you are given here, this is the right ventricle which is collapsed. What is the treatment? Fluid is more, remove the fluid. So you are doing a pericardiocentesis. Remember that pericardiocentesis is not done in all situations. There are few contraindications. The contraindications are aortic dissection, ventricular free wall rupture, traumatic traumatic pericardial effusion or cardiac tamponade. The last one is whenever the patient is in cardiac arrest, pericardiocentesis is contraindicated. So remember these 4 contraindications for pericardiocentesis. They will test you in the exam. Okay, this is in FRCAM they are testing. It is a matter of time they start testing you MRCAM also, because MRCAM exams are becoming tougher and tougher day by day. So to summarize the myocarditis, pericarditis, and how to suspect, how to diagnose. If in the history they give in viral infection and heart failure, choose myocarditis. Viral infection, typical pericarditis, chest pain, that is pleuritic chest pain, worse on leaning forward, better on lying flat, is pericarditis. If they give a viral infection with atypical chest pain, doesn't specify, he says some pain, I don't know, on leaning forward also it doesn't get better, on lying flat also it doesn't get better, then it is a myocarditis. If a risk factor is given like IV drug reducer and prosthetic valve, and a new murmur is given, suspect or pick the option as infective endocarditis. This is very important. This will help you to answer many questions in cardiology chapter, especially on the myocarditis, pericarditis, infective endocarditis. Any questions till now, you can ask me, mainly regarding this inflammation of different parts of the heart.
Doctor, in the prosthetic valve, if less than 1 year is also very dense?
Less than 1 year is, less than 1 year is not very dense, is staph aureus.
Okay.
More than 1 year is staph viridans.
So what are the contraindications for pericardiocentesis in pericardial effusion, sir?
There are basically 4 of them are there. One is aortic dissection. Second one is ventricular free wall rupture, traumatic pericardial effusion in cardiac arrest patients. The main logic here is, why do they say here? If you remember the logic, you'll remember why they're telling here. So imagine this is a pericardial effusion. You put a needle and you're aspirating. Pericardiocentesis, basically you put a needle and you're aspirating. What happens if there is a free wall rupture here? The blood is going here. You keep aspirating, the blood will keep coming still faster and faster. Okay. At least if you don't aspirate, at least it will cause a tamponade effect, and it will cause a tamponade effect, and a clot might form there. Same thing holds good for traumatic or cardiac arrest or an aortic dissection, because the blood is coming continuously there in.
I mean, in pericarditis, leaning forward, pain worse or better?
Leaning forward, usually pain gets worse.
But in your slide, can you check, please?
Yeah, I'll just check it so that it shouldn't be a wrong what I'm. Sorry, leaning forward, the pain gets better. This is the word correctly given. Sorry, apologies for telling wrong. Leaning forward, the pain gets better.
Okay.
Doctor, in any traumatic cardiac tamponade, we cannot do precentesis?
No.
Cardiac synthesis?
No, that's a contraindication.
In the echo picture you show in the lower side, that's not IVC, sir.
Which one?
Blackish in the lower.
This it is not very properly or appropriately taken. It is more often, it's not an IVC, still in the ventricle, it's in right ventricle, what you're saying. Okay, it has to be taken, still more image should have been there. There is an aorta and there is a left ventricle here and right ventricle here. Aorta should have been come, and then right atria. It's supposed to show it's an long axis, parasternal long axis view, what we are seeing here. But important thing is this is the right ventricular, which looks like collapse. It doesn't look like a cavity. Still more important thing, what they will test you is the effusion. The black color thing around the heart is a pericardial effusion. What you need to pick up, that should be sufficient if you can appreciate in this image. Now we are getting into atrial fibrillation. There are various causes for atrial fibrillation. We can remember within pyrates pneumonic. It can be because of PE, ischemia, any lung related diseases. So any respiratory diseases like COPD can predispose, asthma can dispose. So any like CA lung can predispose this one. Thyroid disorders, excessive alcohol, infections, especially the sepsis, atrial enlargement due to a myxoma, a tumor of a left atria. So various causes are there for atrial fibrillation. Atrial fibrillation ECG diagnosis becomes very important. How do we diagnose ECG wise? This is a typical ECG of AF. You can see the rhythm is irregular and there is absence of P wave. So this is an ECG diagnosis of atrial fibrillation. There are few definitions which might be tested in the exam, though they are not yet tested. Definitions are important. New onset AF. This person was never known to have an AF. Now he has an AF. Paroxysmal AF. What do I mean by paroxysmal AF? This patient has AF, but it goes back into sinus rhythm on itself without any intervention. No intervention is required. He gets AF and suddenly it gets resolved into sinus rhythm. No intervention is required. What is persistent AF? He has an AF. When you intervene, it gets back to a sinus rhythm. If you don't intervene, it persists in AF itself. What is permanent AF? No matter what intervention you're doing, this patient will continue to be in atrial fibrillation itself. So these are the definitions for new onset, paroxysmal, persistent, and permanent AF. How to treat a patient who comes to emergency department. If the patient is hemodynamically unstable, that's when you directly go ahead with the shock. Usually we use joules around 120 to 150, and we use the synchronized mode. Sync mode, it should be in the synchronized mode. Okay, the reason it has to be in the synchronized mode, mainly because synchronized mode, it shocks just before the R wave. If you don't shock just before the R wave, for example, if you shock on the T wave, it might trigger an VF or VT. So you will cause more harm if you don't put the equipment, that is defibrillator, in synchronized mode. That's the reason synchronized mode is important. So any AF who is hemodynamically unstable, shock, sync shock. If they are hemodynamically stable and the heart rate is more than 200, heart rate is more than 200 beats per minute, and it is a broad complex, as we saw it can happen in WPW syndrome, then always suspect an accessory pathway like WP or LGL. Okay, that's when you have different options. You can directly shock them or give flecainide or procainamide. This one we have already learned in our ECG class. We can give flecainide or procainamide. Flecainide is preferred in UK, or you can give DC cardioversion. Usually what we do is we consult cardiologist and take their opinion. What do you prefer, cardiologist? We do it. If it is less than 200, and if less than 200, or it is a narrow complex, then we are seeing only two things: whether the onset of time is less than 48 hours or more than 48 hours. If it is less than 48 hours, rhythm control. If it is more than 48 hours, then it is rate control. What do I mean by rhythm control? I want to change this AF rhythm into sinus rhythm. This can be done by by giving a shock, or by doing what we known as pharmacological cardioversion. For pharmacological cardioversion, we use medicine. Electrical cardioversion, we use shock here. Electrical cardioversion usually not preferred. The main reason not preferring electrical cardioversion is it's a painful procedure, and this patient requires conscious sedation. So it requires one more doctor. It requires many things to be done. So it is a little bit of a headache, so no one does it, and patient usually don't prefer doing an electrical. I'm giving a shock. He said, doctor, there is no other option. Yes, there is an option. You're giving a pharmacological treatment. What you're looking for here, first thing, whether there is any evidence of IHD or LV dysfunction. If yes, give amiodarone. If no, give flecainide. If it is more than 48 hours, we are just controlling the heart rate. For example, it is 150 beats per minute, then we are controlling it. We want to bring it down below 120. Usually the target will be below 120. We bring it down by giving beta blockers. Beta blockers is the preferred one. If there is any contraindication, we can think of calcium channel antagonists, calcium channel blockers. We can think of giving those. Heart rate 110, 120, around that range should be fine. Okay. So this should be the management plan. What about new onset AF, not untherapeutic dose of anticoagulants? New onset of AF. He was never known to have an AF at all. Then offer heparin. This is given in the NICE guidelines. Okay. Offer heparin. And this is given in RCM learning and as well as in NICE guidelines. Everything is very important from exam point of view and practical purpose point of view. For example, you're given, a patient is presented after 48 hours, you're given beta blocker, the heart rate has come to 100 or 90. What you will do? You can discharge them, but before discharging, you need to see whether you need to give prophylactic any treatment. That is, thromboprophylaxis needs to be given or not. For that, we are using a score known as CHADVAS-2 score. Okay, the thing you need to remember is age equal or more than 75 carries 2 points. Another point, any stroke, TIA, thromboembolism, any events previously carries 2 points. And rest of the scoring is one, easy to remember. And the mnemonic itself gives away what you need to look out for. Initially, they used to use aspirin and all. We're not using directly. We are giving an oral anticoagulants like apixaban or edoxaban, apixaban, rivaroxaban. Those are the preferred drugs what we are giving now. In men, if the score is more than 1, we directly give apixaban. In women, if the score is more than 2, we end up giving apixaban. If the score is less, we don't give it. This is mainly because AF, atrial fibrillation, what you are having, are predisposed for stroke. So they can have an emboli in the heart, which can go into the vertebral arteries and can cause stroke, or can go into the carotid arteries and enter into the circle of Willis and can cause infarction in anterior cerebral artery, middle cerebral artery, and can cause stroke. That's the reason you need to remember that AF patients need to have a thromboprophylaxis if they are high risk. This risk is by doing CHADVAS-2 score. Again, orbit score is important to predict. It's the same thing what we have used for STEMI and NSTEMI is the same thing, so we will not go through it again. If anyone has any questions regarding AF, can ask me now.
Sir, IV heparin, for how many days we have to continue?
Sorry?
IV heparin, according to NICE guideline, for how many days we have to continue?
We usually give a heparin and convert into oral anticoagulants later on. Okay, this is to bridge the gap between heparin basically has an acute onset of time, so it acts very fast. That's the reason we are giving heparin. Later on, we might convert this into other drugs like enoxaparin, we can convert, or apixaban, rivaroxaban, that kind of drugs usually we convert it. So initially in the emergency, we give heparin. Later on, depending on CHADVAS-2 score, we convert it into apixaban or rivaroxaban, one of the direct oral anticoagulants.
Doctor, for the patient unstable, when we give the DC shock, we're not consider about if the patient before 24, he have this attack before 48 hours or no, we will give heparin before giving the DC shock.
If it is a new onset AF, not on therapeutic dose of anticoagulants, or if he's already on, see, if he is a known case, paroxysmal, persistent, and permanent, he should be a known case of AF already. Then they would have done CHADVAS score, and if he requires any anticoagulants, they would have already given to him. so doesn't require any heparin to be given. If he is a new onset, he is not known to have AF, and this is the first time you're diagnosing AF, then you will offer the heparin. This holds good for in general for everyone. Okay, for everyone in general, what happens?
That synchronized shock should be an RR wave or before R?
Before our wave we do and synchronized shock. Again, it's not we are syncing, is the defibrillator which will sync. You have to just press the button of sync.
Dr. Amin, when we use the chat score and the orbit score?
See, orbit score is to look out for the high risk of bleeding. Okay, if there is a high risk for bleeding, we use orbit score. This is only for high risk for bleeding. Chasva score is to see whether this patient is required thromboprophylaxis or not. If there is a high risk for bleeding, if this score is 4 or more than 4, equal to 4 on orbit score, then no point in doing Chasva score, because it's high risk for bleeding. We are not giving any direct oral anticoagulants. If he is intermediate or low risk for score, then we'll do a Chasva score accordingly, whether to give or not, depending on the score, we'll start it. It's clear? Yes, please.
You said for control the rhythm, we can use fluconide or amiodarone. But when we can use fluconide and when we can use amiodarone, because both for control the rhythm, right?
It's we are basically cardioverting here, patient. This is a pharmacological cardioversion. We use amiodarone if the patient is a known case of ischemic heart disease or known case of heart failure, that is LV dysfunction. Then we are using amiodarone. In other words, if the patient is having any structural abnormality, also we use amiodarone. If there is no structural abnormality, or if the patient is there's no evidence of ischemic heart disease or there's no evidence of heart failure, we use flecainide.
Excuse me, may I ask one question?
Yes, please.
If with accessory pathway, which one is preferred, DC conversion or flecainide?
It depends. If the patient is very much symptomatic, we might DC cardiovert. Again, for DC cardioversion, we need unconscious sedation before we do it. So most of the time we give flecainide and we try it. If it doesn't cardiovert, that's the when we give and shock.
Dr. Amin, if drug management failed, then within
we
48
shock.
hours?
In 48 hours, usually drug management will not fail. We'll try to control the heart rate. In more than 48 hours, control the heart rate. Less than 48 hours, we'll cardiovert. If drug pharmacological cardioversion fails, then we'll do an electrical cardioversion. If both fails, then we'll think of a beta blocker using, and that's when the cardiologist will be involved for further management. It becomes complicated case.
Okay.
Doctor, for the amiodarone, you say this is using for if the patient suspected cardiac problem, or if the patient he doesn't have, we can use also the amiodarone if fluconide is not available or anything. Well, we should
if it is not available, still you can use an amiodarone. But if it's available, flecainide is the preferred one. For some reason in the option they are not given flecainide at all, only amiodarone. If they're given, choose amiodarone.
Okay, thank you.
Okay, that means if there is patient have heart failure, we cannot use fluconide.
Yes.
Okay.
If you see in most other countries, what they see is they don't see anything. In general, like blanket, they'll be using amiodarone. Give amiodarone to every patient who comes. That's another kind of practice, but this is the right way to practice, where you see, and because flecainide is much better for cardioversion, pharmacological cardioversion.
Dr. Amin, I have one question.
Yes, please.
In which type we can use digoxin for AF?
I would have come in heart failure, but digoxin is usually used in heart failure. Heart failure plus atrial fibrillation, we can use digoxin. Okay, I would have told this in the heart failure. As you asked here, good, we'll complete this one. Anyone with an heart failure, with an atrial fibrillation, AF, give digoxin. Digoxin is the preferred one there. Okay.
Okay, thank you, Doctor.
Coming to the syncope. A patient can have a syncope for various reasons. What is syncope? Syncope is transient loss of consciousness. Why this patient is having a transient loss of consciousness? might be because of a neural mediated or because of a postural hypotension, which is also known as orthostatic hypotension, or there might be a cardiac cause. What is neural mediated? It has different kinds. It might be vasovagal, where there is an increased vagal tone triggered by pain or triggered by long-standing or emotional stress. So you have a prodrome. There is a particular situation where the vagal tone has gone high, which resulted in vasovagal syncope. Okay, nothing to worry about. It is a benign phenomenon. Carotid sinus syncope. Pressure on the carotid arteries can cause an syncope. Someone choking you can cause an syncope because of carotid sinus, because carotid arteries get compressed there. It might be a situational syncope. Someone is having coughing a lot, is continuously coughing, can suddenly have a syncope. This is basically because of increase in intrathoracic pressure. There is an increase in intrathoracic pressure. Increase in intrathoracic pressure will cause decrease in venous return. Decrease in venous return will cause the syncope. So decrease in venous return is seen in various situations, or increase in intrathoracic pressure is seen in various situations like maturation or defecation or coughing continuously. That's when you get a situational syncope. What you can see here is history becomes important. If someone is not able to give the history, then diagnosis becomes very difficult. Okay, for example, someone with dementia has a syncope, you don't have a history, then you can't really say what happened unless someone has witnessed it. No one has witnessed it, so we don't know whether it's a maturation syncope or it is an cough-induced syncope. We don't know what has happened. Orthostatic hypotension. By definition, if the systolic blood pressure falls below 20 millimeters of 20 millimeters of mercury when it stands up from a lying down or sitting position, then we call it as an orthostatic hypotension. Diastolic blood pressure, what we're looking is the difference should be more than 10, more than 20 here or more than 10 in diastolic blood pressure. What happens from lying down to standing up? Lying down or your sitting position, usually the blood is pooled in the venous in your limbs. When you're standing up, suddenly the pooling happens more in your legs because of the gravity. So there is not much preload to the heart. So your nervous system, that is basically your sympathetic system, should cause contraction of the arteries or contraction of the veins. Contraction of the veins and arteries will increase the preload. Increasing in this preload, we restore the cardiac output. Restoring the cardiac output will make sure that there is no syncope or transient loss of consciousness. If your sympathetic system is affected, as seen in Parkinson's, a Lewy body dementia, or diabetes, uremia, especially in renal failure patients, you can have orthostatic hypotension. Certain drugs or certain conditions like vomiting, diarrhea, hemorrhage will cause decrease in intravascular volume. That is, decrease of the blood which is there inside your veins and arteries will reduce. It might be because of diuretics, or it might be because of antihypertensive medications, or it might be because of acute GE or hemorrhage. This will cause reduction in preload. Reduction in preload can cause orthostatic hypotension. That is one of the first symptoms what you see in orthostatic hypotension, also known as postural hypotension. Okay. Next come is cardiac. Cardiac, it might be because of arrhythmias, it might be because of valvular heart diseases, it might be because of congenital or cardiomyopathies. These three things we'll be discussing in coming up slides in the cardiology chapter. Bradyarrhythmias and tachyarrhythmias, ECGs we have seen in our ECG class, but how to restate or how to manage them we'll be talking about in the resuscitation chapter. As I was telling you here, history becomes very important. Someone with a postural hypotension should tell you, I lost my consciousness when I woke up and stood up. If the patient is having dementia, it is difficult to get the history. That's when they have come up with a scoring system known as San Francisco syncope rule. It is come up with a person who was in San Francisco, so basically an US one adopted by UK people also. And the mnemonic holds good is chess. where someone has an history of heart failure, or hemocrite value is less than 30%, or any abnormality seen on ECG or on the cardiac monitor, or there is a history of shortness of breath, or the systolic blood pressure is less than 90, admit these patients. So we need to know whom to admit, whom not to admit. If any one of the following is present, admit those patients. So each conditions we are seeing. So this is syncope in general, what we have spoken about. Now we are getting into the cardiac conditions which can cause sudden cardiac death or syncope. One of the most commonly tested in the exam or in any exams is hypertrophic cardiomyopathy. What happens in hypertrophic cardiomyopathy is the septum is thickened. It is thickened compared to rest of the ventricle. When this thickened septum, when the ventricle pumps the blood, especially pumps faster, when you see during exertion, when the oxygen requirement is more, this ventricle starts pumping faster and faster. When it starts pumping faster and faster, this mitral wall comes closer and closer to the septum, and there will be a point, it will be attached to the septum, and no blood will be going into the aorta at all. Sometimes this can result in transient loss of consciousness, syncope. Sometimes it can result in death itself. This is usually encountered or usually first known during the teenage, while they are playing sports like basketball or they're playing football, and suddenly they had loss of consciousness. Then you get an ecodon, then you see there is increased thickening of the septum. Because of this increased thickening of the septum, the blood what is moving from the ventricle into the aorta is hampered, and it causes harshness sound that is known as harsh ejection systolic murmur. There is risk of VT-VF also because of this. What you can do here, you can do a surgical repair, resect it off, cut it off this part, or you can just implant, because these patients are prone for VT-VF, which causes a syncope or death itself. What are the classical ECG findings you see? The classical ECG finding you need to remember is deep Q waves. Deep U waves are basically seen in lateral leads. Okay, sometimes it might be seen in inferior leads. These leads classically look like a dagger. This is the dagger. Okay, this is a knife which is in an in a special shape which is known as a dagger. Okay, what do you mean? How do you see it, or how to appreciate in the ECG? If you see in this ECG, this is an deep deep Q waves you are seeing. Deep Q waves you are seeing. In one also you can see, one it is not appreciated much, but V5, V6 you can appreciate a lot. Same thing you can appreciate in 2, 3 and AVF also. These are deep U waves. This is important. This is a dragger like deep U waves what you are appreciating here. Next one what we are seeing is there is a condition known as arrhythmogenic right ventricular cardiomyopathy. What happens here is the fat tissue gets deposited in the right ventricle. Due to this deposition of the right fat tissue in the right ventricle, they are predisposed to VT and VF. They have a classical ECG finding. What you see is known as epsilon wave. This is the epsilon wave what you are seeing. So let us see this in the ECG how it looks. So what you are seeing here, this part is the epsilon wave, epsilon wave, epsilon wave. Whenever there is an epsilon wave, think of arrhythmogenic right ventricular cardiomyopathy. These patients again are predisposed to VT and VF, so increased risk, so you need to treat. If this finding is in an asymptomatic patient, he never had any symptoms, no syncope, nothing, then you just treat it with anti-arrhythmic drugs. So basically you are not deciding, you just refer to the cardiologist. So he will decide what needs to be given. If the patient is symptomatic, you are admitting this patient for an implantation, that is implanted cardioverter, what you are implanting. Initially, previously they used to tell, do an radio frequency ablation. What do they mean by that? Just burn the fat tissue what is there, then problem is solved. The problem with that is this disease is progressive. If you burn it here, after a few days, they'll have a fat tissue deposit at some other point. So this is no longer recommended. ICD implantation is the recommended one treatment for right ventricular arrhythmogenic cardiomyopathy. What is dilated cardiomyopathy? Dilated cardiomyopathy, especially the left ventricle is dilated. Sometimes there might be dilatation of the right ventricle also. The presentation will be heart failure. So it can present with pedal edema, shortness of breath. On auscultation, there are creps, bilateral creps are heard in the lungs. So features of heart failure they can present. Usually there will be an predisposing factors, or usually there will be a person who is alcoholic, or in pregnancy decision, or he is a known case of ischemic heart disease, or some autoimmune disorders like SLE can present like this. This is not much dilated because this patient comes in heart failure and you treat them as an heart failure. So unlikely you're going to miss it. Echo will be done at the later stage once you're admitted, and they will come to know. The treatment is heart failure, you're done it, so you're not going to miss it. So this patient can, because both are dilated, there is a right and left ventricular hypertrophy. So features suggestive of a left ventricular hypertrophy is predominantly seen that for voltage criteria, you can see here, it satisfies the voltage criteria. It is more than 7 large boxes from here to here if you count. And this one also, if you include, it will be more than 7 boxes, large boxes. So according to our ECG class, it satisfies the voltage criteria for right ventricular hypertrophy. Along with it, if it is in progress disease, it is in later stage what he has presented, there might be right ventricular hypertrophy also, which is diagnosed with a right axis deviation. That is, 1 is negative, 3 is positive, both are pointing towards each other like a married couple. So it is a right ventricular hypertrophy. The last one is restrictive cardiomyopathy. Not tested much because this is usually diagnosed by GPs or cardiologists. Rarely they'll present to the ED as an acute presentation. If they present as an acute presentation, you need to just treat the underlying cause. What happens? What is restrictive cardiomyopathy? This wall, the ventricle wall, is deposited with amino acids, or if it deposited with iron particles as seen in hemochromatosis. These particles depositing here will cause stiffness. It is not able to constrict at all. It has become stiff because of the deposition of iron or deposition of amino acids as seen in sarcoidosis or amyloidosis. These are the only 3 conditions which causes restrictive cardiomyopathy. If at all, if they want to test you about restrictive cardiomyopathy, they will mention about one of this in the stem of the question. Then you can easily diagnose and restrictive cardiomyopathy. Coming to long QT syndrome, here the QT interval is increased. We have seen how it happens in the ECG classes, and in the electrolytes what we have discussed, we know that these are the 3 electrolytes which causes prolongation of QT interval. So there might be an inherited causes like mentioned here. There might be an acquired causes. In acquired causes, the electrolytes are very important, including hypothyroidism, hypothermia. These are the important, and drugs you need to remember. Tricyclic antidepressants, erythromycin, phenytoin. Remember at least these 3 drugs, especially tricyclic antidepressants, phenytoin, erythromycin, important from exam point of view. And remember that amiodarone also can cause prolongation of the QT. Okay, so amiodarone, tricyclic antidepressants, erythromycin, phenytoin. Electrolytes, all are going less. It's an hypocalcemia, hypokalemia, hypomagnesemia, hypothermia, hypothyroidism. Everything is less. Okay, these things you need to remember for long QT interval. Long QT interval are predisposed to polymorphic VT. Polymorphic VT can cause cardiac arrest. So, or it can cause syncope. Okay, short QT interval hypercalcemia, we have already discussed. Other causes for syncope or Brugada syndrome, WPW, LGL, which we have studied in previous class. This summarizes everything related to syncope and ECG. Okay, so in an exam, what happens? They'll give you a stem of the question. At 24 years old gentleman had come to the emergency department with an history of syncope. Now he's completely asymptomatic. ECG has been taken. What's your diagnosis? Or what this patient is on risk for? What is the definitive treatment? What is the diagnosis? Depending on the ECG findings. So this summary, if you can remember, then you can definitely answer one question, if not more than one. Usually 2 to 3 questions will appear from this tabular form what we are given here. Either they might ask Brugada syndrome or something related to the syncope. They might ask risk factors. They might ask definitive treatment. Sometimes even the ECG finding, sometimes lesions. So it is very important. You need to go through this. Anyone has any questions can ask me now.
So how to differentiate between Osborne wave and epsilon wave?
Between an Osborne wave and epsilon wave, it is difficult. You need to go through the history. In both history are quite different. Hypothermia, it becomes easy to diagnose with an hypothermia. Hypercalcemia, usually they'll have in surgical history or something, those kind of history where thyroid is involved, or there will be an CA history, like a person who comes with osteosarcoma and you have a high calcium. So you need to suspect or you need to differentiate depending on the history. Only on the ECG itself, it is difficult because both looks quite similar.
Okay, sir.
Could you please go back to dilated cardiomyopathy treatment? That I didn't understand the treatment heart failure.
Dilated cardiomyopathy, because of the dilatation, again, it holds good here is the Frank-Sterling law. As and when this muscle fibers stretch and get and stretch, till certain point, the cardiac output will increase. After certain point of time, the cardiac output will start falling down. That is nothing but Frank-Sterling's law, what we are talking about. Here, the myocardial fibers are stretched so much that the cardiac output has come down. It is hardly pumping anything now.
There is treatment means heart failure.
Sorry, your voice is breaking.
Treatment, you said heart failure. Treatment, there is no
Heart
medication.
failure is only treatment because you can't do anything which is already dilated. It's usually seen in chronic alcoholics, so you can't do anything much about it. So you basically you treat them on heart failures and they'll be on regular furosemide and all. Basically, chronic alcoholics who are homeless, who just keep drinking, binge drinking, they end up with this disease. Any more questions? So we'll just talk about murmurs and we'll stop the class. Valvular heart diseases will continue from the next class. Okay, I'm just talking about murmurs, how to appreciate it or how to predict it is a systolic or diastolic murmur. Okay, what you need to think out for in a murmur is basically in a murmur, first you need to see which murmur it is, systolic or diastolic. Depending on this, you can easily say, depending on the lesion, you can easily predict it is a systolic or diastolic murmur. First, we'll take an example of, this is in left atria, left ventricle, what we are having. And this is the wall, what we are having. It is stiffened. Whenever the wall is stiffened, stiff wall, it is difficult to open itself. It is known as stenosis. Okay. Whenever the wall is not closing properly, okay, it is not closing at all, it is not closing properly, then we call it as a regurgitation. Okay, these two nomenclatures you need to remember, stenosis and regurgitation. So what happens if the walls are quite stiff? So whenever the, for example, we'll take as a mitral wall. The mitral wall is stiff. So left atria contracts. Whenever left atria contracts, it tries to push the blood through the small opening. It's stiff, it is difficult to open, it's trying and pushing. So there is a friction which is happening. That's why you hear an harsh sound. This is nothing but murmur. What you are hearing, a harsh sound, is nothing but a murmur. When do you see this murmur? When left atria contracts. When does the left atria contracts? During the diastole. So it is a diastolic murmur. Still more also you can see. When the blood flows through this, when it is contracting really hard contraction comes at the middle of the diastole. So it will be mid-diastolic murmur, what you are getting it. Okay. Same thing for mitral regurgitation. As I told you, it is a floppy wall, what you are having, it is hardly closing. Okay. For atria to contract, left atria to contract, it will easily contract and the blood will come away. There will be no friction at all. But what happens when the left ventricle is contracting? Here is there, and it has supposed to go into the aorta. As this wall is not closed properly, it will go and hit this wall and it will become floppy here, and some of the blood ends up going through the friction here because it's not closed properly. It is getting inverted through the friction. It is entering into the left atria. So you are getting an murmur. Okay, this murmur happens when there is contraction of the left ventricles. So it is during systole you are getting this murmur. So it is in systolic murmur. This happens as it is in floppy. If it contracts a little bit, also the blood will start going this. This is because this is a floppy. It doesn't need a lot of pressure to go through it. Okay, so it is seen throughout the systole. That's why it is known as pansystolic murmur. Okay, it is a pansystolic murmur. Same thing holds good for on the opposite side also. Okay, in opposite side, tricuspid regurgitation will have an pansystolic murmur. Same thing holds good for tricuspid wall, which is stenosed. Tricuspid stenosis will have an hard mid-diastolic murmur. Okay, now coming to the other part, that is aortic wall, what we'll be looking for, which is very important from exam point of view. So this is an left ventricle, stenosed, stiffened wall. So you'll be having an harsh systolic murmur. Ventricle will contract during systole. The blood is passing through this stiffened wall, so it will cause an murmur. That is known as harsh systolic murmur. For aortic stenosis, aortic regurgitation. What happens during aortic regurgitation? Let's see. If this is the ventricle, left ventricle, and this is the aorta, these walls are not closing properly. So it pumps. It has pumped all the blood in. Now, so the pressure is here really high. So it has pumped, the blood has gone here. So no murmur will be seen during systole. During diastole, what happens is, due to this floppiness of the wall, the blood will start coming back. It is still in the aorta, yet has just pumped. It's supposed to close it. Because this is empty, the pressure is very low. The pressure is high here because the blood is very high. So due to the pressure gradient, the blood will flow back into the left ventricle during the diastole. So it is an diastolic murmur, what you see in aortic regurgitation. Okay, so murmurs you can remember in that way. For example, in aortic stenosis, what kind of murmur you are? So imagine aortic stenosis, so it is stiffened wall, so the blood will flow during the contraction of a left ventricle. So it is in systolic murmur what we are having. So you usually can remember in that way. If you are memorizing, sometimes you might get confused. You need to remember pansystolic murmur. As I said, pansystolic murmur can be MR, that is mitral regurgitation, tricuspid regurgitation, also in VSD, that is ventricular septal defect. If this is ventricle, this is right ventricle, this is left ventricle. If there is a septal defect, during complete systole, the blood will be moving from left ventricle to the right ventricle. That's why it is known as pansystolic murmur. There are only 3 pansystolic murmurs you need to remember. If you can't remember the logic, then you need to remember each, which is the systolic murmur, what happens, then you need to remember, or you need to really by heart them. I prefer learning by logically, it is easier to remember. So from here, we'll take over into the valvular heart diseases in the next class. After completion of the valvular heart diseases, then we'll be going into the heart failure, hypertension emergency, heart failures. Then we'll be going into congenital heart diseases. Okay, then we'll be discussing the questions. So next class might be slightly longer than this class. Anyone has any questions till now? Whatever we have completed can ask me.
Dr. Amin,
Yes, please.
Type of murmur is important for exam.
Which one? Type of murmur will be important for the exam. What I told how to remember, it will be important. For example, in aortic regurgitation, if they are just given you, for example, this patient is having an diastolic murmur. Okay, diastolic murmur is seen in aortic regurgitation. Where do you see in an aortic regurgitation? Then They might ask you the diagnosis. It will be helpful for the diagnosis. So remembering murmurs will be important. You will not be able to diagnose if you don't remember the murmur. At least you need to remember whether it's a diastolic or systolic from exam point of view. Otherwise, difficult to answer the questions.
Yes, Dr. Amin.
Sir,
In
what is the
AF, you
concept
said
of
Continue. In AF,
you said if hemodynamically unstable, we will go for synchronized DC.
yes.
But you said again this AF with heart failure, we will give digoxin. So which one will, if the answer is both, which one will give? I mean, heart failure always with unstable.
Heart failure, he'll be a known case of heart failure. For example, a patient who is known case of heart failure, he might be on
In case of heart
Samand.
failure, you said we will go for amiodarone.
No. Don't get confused here. Okay. We'll go back to the algorithm here. Yeah. There is an patient is hemodynamically unstable, you directly shock them. So your question is, if the patient is in heart failure, why I said give digoxin? Okay. Yes. Digoxin is in stable patient, what you are talking. Is a known case of heart failure. Okay. That's why heart failure is not the presentation which is not causing the hemodynamic instability here. So he is hemodynamically stable. Okay, he is hemodynamically stable.
You see,
Case of heart failure and
if the
digoxin.
patient present within 48 hours and pharmacological treatment, we are going, if the patient has evidence of ischemic heart disease, LV dysfunction, we are going for amiodarone. So yes. Same, no, heart failure.
LV dysfunction is a heart failure which is contraindication, or we don't prefer giving flecainide in a heart failure patient. That's why we are going to an amiodarone. If you are planning to cardiovert this patient, this holds good for anyone who comes less than 48 hours. He comes more than 48 hours. This when we tend to give digoxin over beta blocker.
If LV dysfunction, we will give amiodarone. If heart failure, we will go for digoxin.
LV dysfunction, for example, heart failure, he's stable. Okay, we're talking about stable patients here.
Yeah.
Heart failure plus he has presented less than 48 hours, then we give amiodarone. Because we want to cardiovert this patient. Cardioversion is always preferred over rate control in less than 48 hours old. Okay. Whenever the patient comes after 48 hours, plus he is in heart failure, then you can give digoxin.
Okay.
Instead of beta blockers.
So it depends on time.
Yes. Time is very important when you're seeing the AF patient.
Okay. Thank you, Dr. Amin.
Sir, crescendo, decrescendo murmur, how we will diagnose?
Which one? Crescendo, decrescendo murmurs is difficult. Usually you get an crescendo murmur if it is a stenosis. Regurgitation is a decrescendo murmur, what you get it. Okay, because once the heart has pumped the blood, once the heart is already, for example, this is in left ventricle and aorta, what you're taking. Once the heart is pumped the blood here, in regurgitation, it is coming back during diastole. The pressure will be maximum at the initial time. So the murmur will be maximum and the blood flow will be maximum initially during the diastole. Then slowly it will go down, 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 down. So decrescendo it is happening. Crescendo usually you see when it is, and stenosis when it is stiffened, because it is struggling to pass through it. Slowly when the left ventricle becomes completely constricted with increased in pressure, it goes. So more and more blood goes as the ventricle contracts and pressure increases in the ventricle increases. So you will get a crescendo murmur. Again, from exam point of view, it's not very important to remember crescendo and decrescendo murmurs. Any other questions?
Doctor, how to differentiate between right ventricular MI and inferior MI?
Inferior wall MI can be an right ventricular or posterior wall MI. Okay. So inferior wall MI itself is a right ventricular MI. You got the point, right? So it is not that inferior wall MI is not in right ventricle. There is any differentiation between this and this. Inferior wall MI means it can be either right ventricle or posterior wall MI. You got the point here? You understood?
Okay, طيب.
Okay.
But
Any
I think,
other
sir,
question?
both right coronary involvement. Huh?
Both is the usually RCA, RCA which is involved. For both, it is an RCA which is involved. Most of the time. Okay. Any other questions anyone has? Just to clarify this. Yes, please. Ask me.
Okay, for that inferior wall MI, in the ECG, I previously learned that if the lead 2 is greater than lead 3, then we should take it as if lead 3 is greater than lead 2, then we'll take it as instead of posterior, we'll take it as posterior.
No, it's not like that. May I say something?
Yeah, you can.
Okay, what I have read and what I have understanding of this, see, in right ventricular MI, you will see ST elevation in 2-3 AVF. Okay, for that, as doctor told, we can do this VR4 like that. But if you are seeing same time elevation in V1 or V2 also, then you may get confused. In posterior, you will see depression in V1, V2, V3, as Dr. Amin told. But in right ventricular MI, you will see elevation in 2-3 AVF. And if you will see elevation also in V1, V2, then you have to decide. In that case, you will see if lead 3 more elevation than lead 2, then you will say it's right ventricular, not anterior wall. Like you are confusing this with anterior wall.
Okay.
Like I confused in one question, same as you are telling, I got confused. I will share that MCQ also with you.
What he's telling is also correct. There is an amplitude, what you're seeing, there is an, depending on the ST segment elevation, how many millimeters it is high compared to 3 and 2, which one is more, depending on that, you can decide whether it's in right or posterior wall MI. That can also be done. I'm not saying it's not can be done. It can also be done. What you're telling is correct. But what I recommend is don't go for that one. Go for a basically right side. You go for V4. If they're given in the ECG, then always it will be an right ventricular involvement. ST segment elevation in V7, V8, and V9, it's always posterior wall MI. That method will be tested in the exams rather than looking for the ST segment elevation, which one is greater in lead 3 or lead 2, depending on that, deciding whether it's in right ventricular or posterior wall MI. That one becomes difficult. Again, you need to count number of small boxes. It will be time consuming. So this method is better. And I'm very sure that this method will not be tested in the exam. Most of the ECG books prefer this method.
Dr. Amin?
Yes, please.
Do you have to take this audio and audio clip of Marmar auscultation in doing the test like this? Only that not like causes.
Your voice is breaking. Can you just talk a little bit louder?
Do you have to practice the audio clip of Marmar auscultation or only to know the cause?
You need to know at least bare minimum. What you need to know in the murmur is which one is systolic murmur, which one is diastolic murmur, which one is pansystolic murmur. At least that much you should be aware of.
Yes. But we don't have to hire the audio clips like auscultation.
Where do you feel it? It depends on the analytical structure, which I'll be discussing when we start the next class. Okay, there are different structures which are the murmurs are felt or heard better in different areas. That we'll be discussing in the next class. Again, it may not be very useful for the examination purpose itself. When we start the valvular heart diseases, we'll be discussing about that.
Okay.
In pericarditis, I have repeatedly said wrong today in the class. That is, it gets better on leaning forward. So usually the patient will be leaning forward. Okay. when only on leaning or lying backwards, the pain gets better. It is a pleuritic chest pain. The main reason is when they're leaning forwards, the cardiac chest wall, the heart comes closer. The heart remains at the same position, but the gap between the heart and the chest wall is more, and there is no friction there. That's the reason the patient feels better. When lying flat, it comes closer to the chest wall and the pain becomes worse. That's the reason patient will keep telling that I can't lie forward, and he'll be leaning forward on presentation. I have told exactly opposite of it when I was talking about pericarditis. So just remember that it's leaning forward. One of you corrected. Thanks for correcting me there. I was wrong in the initial explanation. This is the correct explanation what I'm giving now.
Dr. Amin, in a lateral MI, ST elevation in V5, 6, and 1 and AVL. In your Google question, you accepted LAD rather than LAD plus LCX.
Yes.
May I know why not LAD plus LCX?
Whenever a patient present acutely, it always is an LAD. For example, if a patient is coming acutely and having, it's unlikely that simultaneously two of the arteries have an acute occlusion. If they are having acute itself, it will be an ST segment elevation. If it is not an acute, it will be a Q wave. If it's an old one, so it might be only ischemic changes, ST segment depressions might be there. If it is an acute one, ST segment elevation, then both should occur simultaneously. It is seen very, very rarely that both arteries get involved simultaneously, that they are having ST segment elevation. So most of the time it will be a single artery, that is LAD, it will be in the proximal side.
So if it is acute, we will choose LAD plus LCX.
Which is rarely seen. If it is an old, for example, you might see, and you might see in lateral wall there are U waves, which is more representative of an old MI, and then you might see in anterior leads it is an ST segment elevation. So acutely it is again LAD what is happening. LCX is the old MI what he had.
Okay, clear.
Okay. Any more questions? Please solve the questions before the class from the Google Forms what I'm given there. Those are all old questions. If you have solved it, you can have this kind of doubts and you can ask me in the class. So it will be easier to clarify. Though we are solving at the end, if you can solve before the class and come, you will have a better understanding. You will know what type of questions are appearing in the exam, and what I'm telling, how you need to correlate, you will get a better understanding. So anyone has any more doubts before we stop the class? Okay, we'll end the class here. Thank you, everyone.
Thank you, sir.
Thank you.